Hello, everyone, and welcome to the Academy for Treating Patients with Comorbid Eating Disorders and Substance-Related Disorders with Dr. Timothy Brewerton. My name is Dr. Terry Fasihi, and I'm your moderator today. Before we begin, just a couple of housekeeping items. Wanted to let you know that all participants are muted with the exception of Dr. Brewerton and myself. This webinar is scheduled to last 90 minutes and is being recorded. It will be posted on the AED website shortly afterwards for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Brewerton is going to begin his presentation, after which he will answer questions from the audience. Please feel free to submit your questions to him throughout the presentation using the chat text box on the bottom right-hand side of your screen, and I will read them to him question portion of the webinar begins. Dr. Brewerton, if we could, let's check your volume quickly. Please just say a few words. And if a couple of the participants could let me know if you can hear him clearly, please send a message in the chat text box. Okay, go ahead, Dr. Brewerton.
Thank you, Terry. I'm not sure if other people are picking this up, but it's been difficult hearing you. Your speech is somewhat mumbled. I think there's a problem with your microphone.
Oh,
but hello, everybody. Okay. Welcome to part 2 of this webcast. This part is called Treating Eating Disorders in Patients with Comorbid Substance Use Disorders. It follows from part 1, which was Understanding Eating Disorders in Patients with Comorbid Substance Use Disorders, which we did back in, I believe, March. I do want to give a plug.
Can you hear me better?
Now I can't. Well, it's just after you continue talking, you mumble out. I don't know what's going on. But I'd like to put a plug in for the edited book. It's really a textbook that Amy Baker Dennis and I did called Eating Disorders, Addictions, and Substance Use Disorders, Research, Clinical, and Treatment Perspectives. And this really remains the most comprehensive overview of the clinical science and research science and treatment perspectives in this growing area. So this time we're going to be talking or focusing on treatment, and the problem that we were left with in the last webinar was the compartmentalization of care. And that is based on the fact that the majority of therapies or treatments provided in the eating disorder and substance-related disorder fields are sequential or parallel. And there are very few addiction treatment centers that screen, admit, or treat substance use disorder patients with active eating disorders. Similarly, few eating disorder programs provide integrated screening, assessment, and treatment of substance use disorder patients on site. And even fewer employ professionals trained or certified to treat addictions. Certainly, eating disorder programs typically admit patients with over-the-counter diet pill, laxative, or diuretic abuse, but exclude those with alcohol, benzodiazepine, cannabis, stimulant, or opiate addictions, which are very common, by the way, just in the general population. A recent study showed that alcohol use disorder occurs in 29% of the United States population in their lives. So, and we know that those rates are higher in those with eating disorders. We went over some of those data last time. But this compartmentalization of care leads to consumer confusion, extended time in treatment, increased treatment costs, and compromised continuity of care. Okay. So there are a number of problems with sequential models of treating eating disorder substance-related disorders, and especially when you add in that third trifecta, PTSD, which is commonly associated with the combination of eating disorder and substance-related disorder. Sometimes the PTSD symptoms are masked by the eating disorder and/or the substance abuse. But the problems with sequential models is that patients never make it to the second or third treatment. You get exacerbation of PTSD or the whack-a-mole phenomenon. You get exacerbation of the other thing you're not treating when in either substance-related disorder or eating disorder recovery. So treating the PTSD without addressing the substance-related disorder or eating disorder may not be effective. And this is, you can insert any one of these into the other, and it's the same story. If you focus just on one disorder, then the other ones do not necessarily just get better by themselves. They often get worse. And when you have sequential models of care, there are often discrepancies in treatment approaches for these disorders, so that there's not a sense of continuity or integration. With different therapists, and there are more than one treatment episode, there's a lot of confusion and there's often poorer treatment outcomes. So what is integrated treatment? This is actually something that's been detailed for psychiatric disorders in general at length in the past. Amy Baker Dennis, Tamara Pryor, and I came up with a working definition of integrated treatment of ED substance use disorder patients, and it includes comprehensive screening using evidence-based screening and assessment instruments, which we talked about last time, a complete medical evaluation, including review of systems, physical exam, laboratory work as needed, an individualized comprehensive treatment plan, which often is not done, and we'll talk more about that. Services provided by therapists and treatment teams highly skilled in the delivery of evidence-based treatment for all of these disorders. Services provided in the same location by the same providers using stepwise integrated approaches. I know this is an ideal that many clinicians out there are not able to do, but we talk about it takes a village just to treat eating disorders. It takes a team of different disciplines and professionals to treat eating disorders. But you want to be as close as possible, ideally in the same location or office. But at least you want to have people that you're working with who understand each other and understand these problems, and you can be on the same page with. And then it involves development of a specific plan for patient movement through the different levels of care to other integrated treatment programs to ensure continuity of care. So, ultimately, if you're working in an eating disorder program, then you have to discharge people unless people are local to where the program is. And more often than not, they're not terribly local. They have to, go back to outpatient programs that may not be so integrated. So, you need to pay attention to what the referrer, as well as, the referee, is doing, and discuss that with the patient. It involves development of a plan or contract with outside services utilized during treatment but not available on site. Now, this includes things like methadone maintenance, or this prescription of Suboxone, for example, in opiate addiction, 12-step meetings, which are there for certainly most substances, if not all, and now there are a number of 12-step meetings that some people with eating disorders find useful. The rationale for integrated treatment. There's been a significant movement in mental health towards integrated treatment that's gone over the last several decades. Although it's kind of there's been a lack of research in this particular area that we're talking about today. But the research in general about integrated treatment shows that when you have integrated treatment, you have reduced substance abuse, you have significant improvement in psychiatric symptoms and functioning, you decrease hospitalizations, you have fewer arrests, and you have increased housing stability. And last but not least, improved quality of life. Now, this research has been mainly focused in major psychiatric disorders such as schizophrenia, bipolar disorder, severe major depression, along with substance abuse. But there are no studies to date comparing sequential or parallel treatment for ED SUD patients to integrated treatment. And so there is a great need for this kind of research to be done. But we hypothesized that the integrated treatment approach would improve treatment delivery, reduce time in treatment, lessen consumer confusion, reduce overall treatment costs, and improve treatment outcome. So in terms of an integrated treatment model, again, to emphasize, all conditions treated concurrently by the same clinician. The integrated model is driven by the hypothesis that substance-related disorders and eating disorders are in part a result of PTSD symptoms or severe trauma, and/or that PTSD symptoms are perpetuating factors for both of these conditions. And I would have to say that in probably 90% of the people that I have seen who have serious eating disorders and substance use disorders, there is a history of significant trauma in PTSD or partial PTSD. To me, it is definitely by far the rule rather than the exception. And we have reason to believe that reductions in PTSD are more likely to lead to reductions in substance-related disorder ED symptoms than the reverse. I've seen all too often focusing on just the substance use disorder or just the eating disorder without integrating the focus on PTSD does not work, and it leads more often to relapse because these trauma symptoms and PTSD symptoms are unrelated. And often the clinicians don't really make a case for including trauma and PTSD. They're not truly trauma informed. And of course, we want to hear about patient preferences. And often I see, as an outpatient provider at this point in my career, people want incorporated care or integrated care, but they can't find it typically. So when you are doing integrated care, you can't just have a hammer and expect that everything is going to be a nail. And this is actually a saying that I found out came from Abraham Maslow, which is the father of humanistic psychology or transpersonal psychology. And it makes more sense than not. I mean, you may be a certain school of therapists. Some people say I'm a CBT therapist, I'm a DBT therapist, I'm an ACT therapist, I'm a psychodynamic therapist. And I think that's short-sighted, in that you have to have, ideally in this day and age, a number of tools in your toolbox. Just using a hammer for everything does not and will not work. You have to have a lot of different tools in your bag. And if we look at just the evidence-based approaches for eating disorders as well as substance use disorders, we find that there are a lot of overlaps. And certainly CBT is one of those. CBT has been found to work not only for there's evidence for all of the eating disorders. If you think about Fairbairn's enhanced CBT for eating disorders, as well as lots of evidence that CBT works for substance use disorders. It is not simply a matter of going to AA or NA, as a lot of people mistakenly think. In the MATCH study done in the 90s for alcoholism, CBT was compared with motivational enhancement therapy, and as well as 12-step facilitation, which you see on the left for substance use disorder. And all three of these approaches worked for people with alcoholism. and they were no different in terms of their responses. The whole idea of Project Match was to match certain psychotherapies to clinical characteristics, and by and large, they were not able to do that. Now, 12-step facilitation does not mean going to AA meetings. It means going through the workbook, the 12-step process with a therapist, step by step, page by page. That is what has been shown to be helpful. And then you have motivational interviewing and motivational enhancement therapy, which originated in the substance use disorder field, which has been applied to eating disorders, even though I don't have it listed. Medications are certainly used, and family therapies are used. People are all about FBT, particularly in the adolescent population, but family therapy, family involvement is very important at whatever age people are to facilitate the treatment plan. And then, Cindy Bulick's couples therapy called UCAN. There's really good data published in press about the effectiveness of couples therapy for anorexia nervosa in adults. And then people probably know about SSCM, Specialist Supportive Clinical Management, or med management. The same kind of approach has been done for substance use, particularly most notably opiate addiction. And then we have interpersonal therapy, which there's evidence for eating disorders, particularly bulimia nervosa and binge eating disorder. There's now evidence for IPT for PTSD. It's not been terribly studied in substance use disorder, but the point here is that there are therapies effective across eating disorders and substance-related disorders, particularly the motivational interviewing enhancement therapy, cognitive behavioral therapy, meditation or mindfulness-based approaches, which is part of DBT, as we'll talk about, but mindfulness has now been linked to CBT, mindfulness-based relapse prevention. There are so many different approaches in the substance use field, the eating disorder field, the PTSD field that incorporate the practice of mindfulness, that it has really become a mainstream approach. Contingency management is very much used in substance use disorder. A lot of people in the eating disorder world are not familiar with it, but it's part of what DBT does. It's part of what FBT does. And then I've mentioned the self-help 12-step approach. It reminds me of the growing science about food addiction, which I know is a very controversial area for a lot of people in the eating disorder field, not so much in the substance use disorder field. In my view, there is a lot to this, and it's something to pay attention to. And what's important here is that if you meet criteria for food addiction that's based on the Yale Food Addiction Scale, it does not mean that you have to go to OA or abide by the OA steps. There's research showing that CBT is effective for people with food addiction. So there's a lot of overlap across these disorders, and it's often how we conceptualize them. Family therapies are very important and have been applied to this population and related population, eating disorders, substance-related disorders, and related conditions. And we'll talk a little bit about that more as we continue. This is a very important study that I've put in here. It's from Clinical Psychology and Psychotherapy 2012, and it's from Canada, and participants were randomized to DBT versus treatment as usual. It is a small sample size of just 25 female outpatients, but they had concurrent eating disorder and substance use disorder. And they showed that with the DBT condition, they had much better treatment retention and follow-up in the DBT group. And they had a very significant positive effect on behavioral and attitudinal features of both disordered eating, substance use, and substance use severity and use, as well as improvements in negative mood regulation and depressive symptoms. So I think this is the only study, to my knowledge, that's double-blind controlled that shows that any kind of approach works in the eating disorder, substance use disorder area. So it's one of the integrated treatment approaches that we should think about incorporating, and that was full DBT, but at least we can offer DBT skills training. Certainly you can do that as an outpatient. Most places, or not all, but certainly many, have DBT skills training at least available, and you have full DBT often available as well. Most programs that I know of in the country have incorporated DBT into their residential PHP and IOP programs. It's a very important component in terms of learning these skills of mindfulness, as I've mentioned, but also distress tolerance, emotion regulation is often a major issue in this comorbid population, as well as interpersonal effectiveness. It's notable that in the substance-related disorder PTSD field, there are integrated treatment approaches that have been studied and are being studied. Lisa Nodjevitz, Seeking Safety, showed efficacy initially, and then COPE, which is concurrent treatment with prolonged exposure. It's a combination treatment of CBT and prolonged exposure for the substance-related disorder and PTSD population. And it's something that you could easily add to the mix with an eating disorder person. There are DBT prolonged exposure combos that have been researched out of Seattle that focus on those with borderline personality disorder and PTSD. A lot of our patients have that. Borderline personality shares a lot of characteristics, particularly with people with eating disorders as well as substance use disorders, and it can be applied. And I know it is being applied in certain treatment programs in this country. And then eating disorder PTSD, there is new data emerging using a combination of CBT and cognitive processing therapy. Another program I know has been using DBT CPT combination. And then there is Jacqueline Person's case formulation approach, which can be used pretty much for any combination of comorbid approaches, which is taking a scientific approach toward an individual patient, where you're making, you're looking very closely at adaptive function and what's the function of these different disorders or symptoms in the overall life of the person. And we're going to talk more about that. But there are no integrated treatment approaches that have actually been tested in substance-related ED and PTSD populations as of yet. Just to say a little more about COPE, it's a synthesis of two theory-based and empirically validated, largely CBT-based approaches: prolonged exposure for PTSD and relapse prevention for substance use disorder. And that's what we do in clinical practice, isn't it? Is that we synthesize what we've learned. We use multiple tools, not just hit everything with a hammer. So when we add PTSD to the mix, we see again that CBT, along with particularly PE, is involved. And this is nothing more than exposure with response prevention is another word for PE. And cognitive processing therapy is a type of cognitive behavioral therapy. Emphasize the cognitive that has been applied very successfully to PTSD. People know about EMDR. Again, DBT is showing efficacy in PTSD. I'll show you some data on that later. And now IPT, as I mentioned earlier. And then yoga is now very much a mainstream approach for those with PTSD, and it's also something that is incorporated into eating disorder and substance use programs. And this is the book on COPE. It comes from colleagues of mine at the Medical University of South Carolina, as well as Edna Foa, who originated the prolonged exposure therapies for PTSD. So just to review the principles of treatment, you have to have a complete psychiatric evaluation. It's very important to identify all the diagnoses so that you avoid misdiagnosis. PTSD is often missed. Substance use disorder is often missed in certain populations, and eating disorders are certainly often missed in those who focus on addictions. And as you hold all of these diagnoses and problems in, it's a juggling act. As you hold them together, therapeutic alliance is pivotal. And because comorbidity is known to predict dropout rates. So it is very much a challenge, but your best bet is someone who has multiple skills, multiple tools in their tool shed, who knows about these disorders and how they relate to each other. And you start by looking at the relative chronology, by building a timeline. What came first, what came second, what came concurrent. You look at the adversity and events that are significant adverse events in persons' lives, when the onset of their problems occurred. And then that helps you identify functional links between disorders. It helps you build a case for the functional, adaptive function of these symptoms and disorders, which often amounts to avoidance of trauma-related memories, affects, behaviors, cognitions, and cues. The old self-medication hypothesis, but applied to eating disorders. People use starvation, binge eating, purging, exercise, and use of appetite suppressant medicines, often in the guise of self-medication, to dampen not only appetite but emotions and all of these other things that are related to traumas often. And so you want to treat concurrently when possible. Of course, you can't do more than one thing at a time. But you can build the bridges. You can build the bridges, and it's a matter of emphasis or focus, and that's determined by the level of dangerousness, risk, or body-brain impairment. We'll talk more about that. But good case formulations, which are really important in getting the big picture. Our patients have trouble getting the big picture. So it's important that we help them get the big picture by getting the big picture ourselves. And so case formulations require a comprehensive understanding of the 3 Ps: predisposing, precipitating, and perpetuating factors across the biopsychosocial spiritual continuum. To understand the adaptive function of the patient's symptoms and behaviors. To look at a detailed timeline that outlines the sequence of symptom onset, along with the significant life events in a person's life. An understanding of how symptoms are functionally linked and affect each other. So this is my overall integrated treatment pathway, treatment planning. It's actually a recovery pathway, integrated treatment planning template, I like to call it. And I'm going to show this slide a couple of times in the course of this talk, but it encompasses a lot of what I'm talking about today. That you start at the upper left hand by getting a good history and really doing a comprehensive evaluation where you assess diagnoses and status, not only psychiatrically or psychologically, but medically. And you focus on the problematic behaviors. Now, sometimes detox is very important, but before anybody's going to do anything, they have to be ready to do it. And that's where motivational interviewing and knowing something about that and having that as one of your tools in your toolbox is so important. Motivational enhancement therapy was based on MI, and this came out of Bill Miller's work in University of New Mexico, where literally hundreds of papers have shown its efficacy in this, starting with the substance use disorder field, but also expanding out to refractory medical problems, to eating disorders, to so many different things. And then you can start with behavior. If people are ready to move forward, you start with behavior monitoring of whatever the whatever the focus or target symptoms or behaviors are, which are listed there in red. You build in response prevention, particularly if you're in a structured setting, but if you can do that in family work, you can do it in couples work, and very important, I believe very strongly in, is psychoeducation about all the disorders. And then we know that involving a nutritionist, a dietitian to do nutrition therapy is often an essential component. Not only in the eating disorder world, but in the substance use disorder world, there are a number of vitamin deficiencies, nutritional deficiencies that go along with these kinds of problems. But we're looking to reduce or stop these behaviors along with weight restoration or normalization of eating. And these are goals that I know you're all familiar with. And then we're moving toward abstinence and our harm reduction. And as we all know, abstinence is not always achievable. And it used to be back in my day where you were taught that, it was kind of an all or nothing thing. And if you didn't achieve abstinence, then you failed and the person has failed. And there was that attitude. But since then, this has softened, and the idea of harm reduction has taken its place. And that's an important concept, not only in substance use world, but the eating disorder world as well. And so at the top, we see, as you move toward that, and hopefully an eventual maintenance of improved state and hopefully ultimately remission, even though we know that that is not often achieved or always achieved. I don't know that it's often achieved in those who have this combination of disorders, particularly when you add PTSD to the mix. But you identify the adaptive functional links, as I said, and you move toward treatment and resolution of underlying disorders, whether it be PTSD. Sometimes you have to treat people for OCD, you have to treat them for more generalized conditions, but normalizing nutrition is one important movement toward that. A lot of times depression or mood disorder symptoms will improve with weight restoration. Sometimes they don't. There's now good data to show a link between ADHD and other impulse control disorders and all of these disorders, both eating disorders, substance use, and PTSD. And then, of course, we have personality disorders or traits. My particular preference or inclination is not to make written in stone personality disorder diagnoses until you've moved toward closer toward abstinence and harm reduction, and you can't attribute it to being undernourished or PTSD or severe emotional dysregulation. And we see that a lot of these disorders, so-called disorders, particularly borderline, that's probably the one that we've been, as a mental health community, most guilty of diagnosing borderline personality disorder too prematurely. We had a lot of these, what were previously called Axis 2 disorders disappear or get significantly better with the treatment of the Axis 1 conditions. And so we have the number of interventions at the bottom and the middle. Psychopharmacologic interventions are often very helpful early on for stabilization, particularly of mood dysregulation, and to help with distress tolerance. Pharmacologic interventions tend to be helpful when you have comorbidity. Most people with significant comorbidity need adjunctive psychopharmacologic interventions, not as the exclusive approach, but as adjunctive medication-assisted therapies, as the term is used in the substance use world. Cognitive therapies, cognitive processing of some sort. You've already started the behavioral monitoring very early, looking at certain behaviors, but there are very many different variations of cognitive processing. You see it in CBT, with PE, in cognitive processing therapy, in EMDR. You have cognitive processing in DBT. And these four skills, as I've mentioned, the stress tolerance, interpersonal effectiveness, mindfulness, emotion regulation are core components of DBT, which of course is a second generation cognitive therapy. Now, a lot of people ascribe to ACT, acceptance and commitment therapy, and there are a lot of very good concepts in ACT. In particular, I find the values identification piece of ACT to be very important in working with these comorbid folks. But the clinical research data is not in. We don't have really good outcome measures about the usefulness of ACT in this particular population. And I hope somebody is working on that and doing that, because it does have a lot of potential. In particular, it's focusing on experiential avoidance, which we certainly see in this population. I've mentioned family therapy. I'm going to talk more about that, as well as 12-step facilitation and these other alternative approaches, which are not so alternative anymore. And then as you move, if and when you move toward maintenance and remission, we all know this, that people relapse, don't they? And there's often a very high rate of relapse, particularly with anorexia nervosa, but with all of the eating disorders. And sometimes you have to go through these cycles, perhaps focusing on different aspects of it that haven't quite been fully addressed or resolved. And we'll come back to this, this template again. I want to mention something about the principles of harm reduction. This was developed in response to the excesses of a zero tolerance approach. Everybody knows about the drug war that has been waged for decades unsuccessfully, and it emphasizes practical rather than idealized goals. It's grounded in the evolving public health and advocacy movements, and it's grounded in seeing addiction as an illness rather than a crime or a moral shortcoming. And it's developed evidence over the years. It's proven to be effective. It's gained increasing official acceptance. It's now the basis of Canada's drug strategy, and other countries have adapted it. And, the principal feature is acceptance of the fact that some drug users cannot be expected to cease their drug use at the present time. Now, does that sound familiar in those of you who work primarily with eating disorders? Do we sometimes need to accept the fact that some eating disorder folks cannot be expected to cease their eating disordered behaviors? We see this certainly in anorexia nervosa. And it has led to the realization that some are severe and enduring, and that we need to alter our goals, and we need to be more collaborative, and we need to listen to what these particular individuals who have suffered for years want. Because often, if we're too gung-ho, we end up traumatizing people through our best efforts by forced tube feeding, for example, or forced hospitalization when there's really no readiness to do these things. There is a literature about harm reduction psychotherapy, and certainly the whole idea of medication-assisted therapy is part of this harm reduction approach. And specifically, for those of you who may not know much about this, there are medications for opioid use disorder that are assisted. These are all adjunctive and not, they're prescribed in conjunction with psychotherapy and behavior therapy, which is a kind of psychotherapy. There's methadone, which has been around a long, long time, still relevant. A lot of people do better on methadone. Buprenorphine, and then naltrexone for alcoholism. Revia, which is now off the market. Naltrexone is available as a generic for oral use, and then there's Vivitrol, which is a monthly intramuscular formulation. And then there's combinations of buprenorphine and naltrexone called Suboxone or Subzolve. One is a pill and another is a strip. which are very, very useful in the treatment of opioid use disorder. Although the data are, supported, although there are people who don't like it. Just last night, Sanjay Gupta on CNN broadcast his Weed 4. This is a series that he has been doing for some years, and he's focusing on the use of marijuana, particularly cannabidiol, which is a non-psychoactive form of marijuana in the use of opiate addiction. And there's actually a lot of promise for that. If you didn't get a chance to see it, I'm sure it's going to be reshown, or you can get it on demand for CNN. For alcohol use disorder, disulfiram has been around for many, many years. It may be helpful in the initial stages of abstinence. It basically makes people sick if they drink any amount of alcohol. So it's ideally a symbolic commitment to not drink. And it can be used very helpfully in the context of couples therapy or family therapy. Because often, certainly alcoholism, as well as any other addiction, can wreak havoc, as can eating disorders, as can PTSD, wreak havoc on families, not just the individual. Acamprosate is another drug on the market. It's for the relapse prevention for alcohol only, whereas naltrexone not only can be helpful for alcohol, it's obviously effective for opiates. It can be really helpful for some people. For other conditions, there's recent data that naltrexone can be useful in preventing or dampening stimulant use disorder. So it's been used and tried in binge eating disorder and bulimia nervosa with mixed results. And it's now one of a combination treatment for the treatment of obesity, along with bupropion. It's called Contrave, which is a combo drug of naltrexone and bupropion in the treatment of obesity. And for tobacco-related disorders, which many eating disorder folks have, and particularly those who are traumatized, there's nicotine replacement meds that can come in gum, patch, lozenges, all over the counter, but you can get a prescribed inhaler or nasal spray, which is much higher concentrations, which can be more effective. There's bupropion, which is contraindicated in active eating disorders, but it's just something for you to know about. A lot of doctors will give inadvertently our eating disorder patients bupropion, which should not be done because it is big black box warning in the PDR that it should not be given with anybody with an eating disorder because of the increased risk of seizures. And then there's varenicline, which is used for tobacco-related disorders. So I want to move on to talk about some of the therapies that I've highlighted, in particular motivational interviewing. And rather than thinking about it as a type of therapy, I think it's really meant to be an evidence-based collaborative conversation style for strengthening a person's own motivation and commitment for change. It's a way of approaching people, and it's highly applicable across the board. It has transdiagnostic power. It's been used in medicine and treatment, of very difficult to treat chronic medical patients, diabetes, what have you, because not everybody is willing or ready to even take their insulin or measure their blood sugars, much less work on their substance use, PTSD, and eating disorder. So this is something that I strongly recommend that clinicians learn about, get trained in. There are manuals, books written. Third edition is out by Miller and Rolnick. This has really been around now for many, many years. I think most people get some exposure to it, but I think improving your skills on it in terms of whatever you have to do can be very worthwhile. MI has a number of principles in terms of MI style and skills. The ACEs: autonomy, collaboration, evocation, and compassion. You'll see that this overlaps with other approaches. You know, Howard Steiger has been talking a lot about the autonomy in the treatment of eating disorders. This has been getting a lot of attention. That we can't really make anybody do anything, can we? We have to work with them, and we have to assess their readiness, and develop a sense of collaboration, and while we stay compassionate, which certainly a lot of trauma-informed care principles use these same principles, and a lot of psychotherapies are also now very much invoking these. Certainly psychodynamic psychotherapy has talked about this for some time. In terms of the MI skills, using open-ended questions, being very affirmative, using reflective listening, which harkens back to the old Rogerian, but it's much more than Rogerian. It's giving summaries that, again, you get affirmation or not, whether you're actually hearing them correctly. So it gives patients and clients a sense of affirmation when you reflect back and you're getting it right. So the four fundamental processes are engaging. It's relational in its foundation. It's patient-centered. It then moves toward focusing. As you listen for change talk, that's what you're doing in MI. You're listening for, and then you're evoking change talk, where you're focusing down, evoking certain responses about willingness to change, and what are they willing to do, interested in doing, what ideas do they have, in terms of bridging to change and making a plan, negotiating that with them, consolidating their commitment. And then it ends up being their idea rather than your idea, which is a much bigger, much smaller pill to swallow for most people. So engaging, you can ask things like, what is bothering you? You're using Socratic questioning, which is, those of you who may not know, cognitive processing therapy is really based on using Socratic questioning, as is many approaches of CBT. What do you want to be different? What is not working? How do you want your life to be? That borders on the values identification that ACT focuses on. What is important to you? What do you want to accomplish with the time we spend? Focusing, you're guiding the conversation in a therapeutic direction. You may have feedback about substance use and eating disorder behaviors. You're asking more focused questions. How does your substance use affect your eating habits, or vice versa? Making more complex reflections that allow patients to examine other perspectives. So, for example, you're using marijuana to help you focus better, however you find it causing you to binge eat. You notice that since you started drinking more, your weight is fluctuating. So you're reflecting back what people are telling you as they share their stories and histories. Part of it is, in this population, is you're exploring the relationship between ED and addiction. These are some suggested questions. In the interest of time, I'm going to move on. But asking them, what happens to one disorder when you treat the other, and vice versa? Again, this is getting at the functional relationships, at the adaptive function that we're talking about. Evoking, you're looking for change talk, particularly talk that favors movement in the direction of change. You're looking for self-motivational statements, problem recognition, concern, desire, intention to change, and ability to change, as opposed to doing what other people want them to do. And often there is this defiant oppositional component to substance use addiction as well as eating disorders, right? Motivational statements are amplified and non-motivational statements are dampened down, or if not ignored. and it's specific to the particular targeted behavior change. So a lot of times it's really important to assess people's readiness once you identify certain intention to change or thinking about change. Well, how important is it to you to make that change? How confident are you that you can make this change? And you can use a simple 0 to 10 readiness ruler. And this is a very important component of using MI in motivational enhancement therapy. So MI and MET can help establish treatment goals. Where do you want to start? Does that make sense to you? You can ask them, can I give you my opinion about that? So a key useful tidbit for MI is that you don't just tell people what you think. You ask them permission first to tell them what you think, which is a really important tool, I think, or strategy. Ideally, you want to focus on goals that include behaviors associated with both or more disorders. And then you get to the point of asking, what do you think is a reasonable step that you can do that may move you closer to your goal? And we're talking about right now, of course. And of course, this is a moving target. So this is a process that you engage in from the beginning that's collaborative and compassionate. So depending on the response, the patient may want more information. So again, it's focused often on psychoeducation. And in order to be a good teacher or educator, you have to know the stuff yourself. And so this is where eating disorder therapists do well to learn more about, realize what you don't know, realize that you don't know first, realize what you don't know, and then make an effort to fill in those gaps so that you can be more effective and treat this comorbidity, which is the rule in your patients, not the exception. So for patients who are concerned, you elicit what they want to know, what do they need, you provide it, and then you elicit again. You process that, find out, well, okay, how is is there a change in their change talk, in their readiness? So it's often about, using the cognitive concept of framing, how you help them frame these links between their eating, their substance, their possible life experiences. For those who are not concerned, you may raise awareness. You may verbalize concerns. You may have concerns that have been expressed by family members or by other providers that referred them to you. So you can just bring these things up and see what kind of things or feedback or response you elicit. And then you move toward a change plan worksheet. What are the changes you want to make? The steps you plan in taking, the ways other people can help you, who it is, possible ways to help, and then to facilitate them asking for that help. So right there you have a built-in assertiveness, which is again a part of CBT. And how do you know whether your plan is working? What do you anticipate are some of the things that could interfere with your plan? So you're taking a very realistic approach. Now I want to, doing MI is a great segue into doing cognitive behavior therapy. And cognitive behavior therapy is a mainstay treatment in the substance use world as well as the eating disorder world. And so presumably all of you out there probably know something about doing cognitive behavioral therapy for eating disorders. The same exact principles are used in treating substance use disorders. Now you have a different set of educational data, but because that's often a component of it. So there are core sessions, and then there are typically elective sessions. And in terms of the substance abuse, a lot of these, are familiar with, coping skills, managing cravings or urges, managing thoughts, problem solving, planning, dealing with lapse and relapse, seemingly irrelevant decisions, refusal skills, and assertiveness, in my view, is really one of the most important things, particularly in the eating disorder world. And then on the other side of it, managing anger and aggression, awareness of anger and aggression, increasing pleasant activities to develop some other way of experiencing pleasure is very important. Receiving criticism, not reacting to it in the same way with anger or avoidance, either aggression or avoidance, and managing negative mood states. So these components are very similar across disorders. Way back when, in 1997, over 20 years ago, Stuart Agris and Robin Apple integrated Fairbairn's model of cognitive behavioral therapy for disordered eating, integrated it with abuse of alcohol and drugs, which often are started to reduce the desire to eat, to feel better in terms of emotional regulation. And you can see that it can easily fit into an integrated overview using a cognitive behavioral model. The approaches often have to do, again, with cravings, as opposed to identifying legitimate hunger, identifying triggers, and how that event or trigger or cue leads to thoughts, which are associated with feelings and behaviors, and then which are part of the response, and then consequences. And often they are negative. This, I'm sure, is a review. You challenge irrational or unsupported thoughts. What is the evidence for the thoughts that once you identify them? You help people learn how to manage stress. You're addressing assumptions about appearance, negative body image, failure, self-worth. The same stuff in substance use disorder, substance-related disorders, and PTSD. You're helping them move toward pro-social behaviors and behavioral activation. So cravings should be explored, and I like the metaphor of surfing. You define the craving. How long do they last? The thing is, they don't last, however long they last, they don't last forever. And you can draw this out for the person. And this is mainly in terms of their use, but using use liberally in terms of using food or purging or exercise. It's the same kind of thing, and you can plot out the craving in terms of a 0 to 10 scale, and you can plot it out over time, and you can, again, use logic, use reasoning to help people see that these don't last forever, and how important it is not to react to them, but instead to urge surf, experiencing the craving in a new way. Using mindfulness-based techniques is very effective in just watching the craving. The craving is not you. It's something that you're experiencing, and you can look at it and experience it in a way that's non-judging and develop compassion for yourself. Identify where on your body, in your body, that craving is experienced. So becoming an observer, delaying decisions, invoking their frontal lobes, which we know can be impaired in both particularly bulimic disorders and substance use disorders, as well as PTSD. Using distraction appropriately, but not exclusively, but good kinds of distraction, positive kinds of distraction. Learning how to play it out forward. Again, this is a frontal lobe function. So thinking out, sometimes people have talked about write out the binge or write out the purge. The same thing with, the substance use. We'll write out the use. If you just drank one beer, what would happen? Write it out. If you thought just one beer, what does that really lead to in your experience? What do you think? And learning how to breathe is, in my view, an essential component of all of this. So everybody knows about the ABCs. It's commonly used in cognitive behavioral therapy. Activating event, beliefs, and consequences. I'm going to skip over that, as well as the event, thought about the event, the response to event. This is something that I think most people are familiar with. You end up in cognitive therapy challenging cognitions, whatever they may be about. For example, I can't handle this. Well, you ask, well, what's the evidence? Pros and cons. You develop an internal argument, if you will, or debate is probably a better word for it on the left bottom, where there are different parts of you that think different things, and part of you, believes I can't handle this, and then part of you doesn't, and you can, elicit each of those parts to say, what's the evidence that you can't handle this? Well, part of you probably knows that you've been in similar situations and have done well. Maybe I can step back, do a little breathing exercise, and think more clearly, which leads to more confidence and control. And of course, this has to be done repeatedly in the context of cognitive therapies. Developing alternative, more helpful ways, putting it into perspective, looking at goal-directed thinking, and so on. There's a managing thoughts, skills worksheet, the negative consequences, the positive rewards, getting people to write it out, think it through and write it down is very helpful in processing information. The cost-benefit analysis is often useful in the context of CBT, where you do pros and cons of changing or staying the same. Helping people understand the difference between lapse versus relapse. Lapse is just, people think in all or nothing terms, right? Lapse is simply a one-time use or return to ED behaviors. It's not the end of the world. Confucius say, man fall off horse 1,000 times, get up 1,001, which is a saying I use a lot in the course of therapy. It's not the end of the world. Relapse is where you're returning to the pre-treatment level use of pre-treatment use or level of ED behaviors. It's when you go back and meet full criteria of the disorder again. That's a relapse. But there's this abstinence violation effect, which is used in the addiction field, a lapse that elicits an all or nothing behavior process, or all or nothing thought process, followed by continued symptomatic or problematic behavior. Oh, well, I'm a failure. I might as well just go back full tilt. And so this is part of relapse prevention, is for eating disorders and substance use, and certainly those with both, that you talk about this, that it's a way to help prevent the whack-a-mole phenomena, to help them focus on what's really important. And so the benefits, I think, are obvious in terms of increasing efficiency. They only have to bond and attach to one therapist, and they're treated as a whole person. It reduces the logistical issues. Dropout, as I said earlier, is more likely with sequential treatment, and it's certainly more cost effective. It decreases any discrepancies between the disorders. Abstinence is something that may be used in one field versus the other. There's still addiction centers that focus most on abstinence. There's still eating disorder therapists who focus more on abstinence, of particularly restricting, binging, or purging, or what have you. But again, it's important to speak the same language about this, and the same language applies to both fields. Again, exploring the relationships, and that's how you develop this functional integration, that they're not just two compartmentalized separate problems that don't have anything to do with each other. So we think that eating disorder is not likely to improve with just substance use disorder recovery. I think, many people have experienced that. I certainly have. Those in SUD recovery may be at risk for development of an eating disorder behavior or exacerbation of an eating disorder. And often that's for the bottom reason, because the trauma in PTSD or partial PTSD has not been addressed. Or their depression and anxiety, which can certainly improve with ED SUD recovery or treatment, but it's often not completely gone or in full remission. And often it's because they're just becoming more aware of the damage that their conditions have done in their lives and in their families and in their careers and so on. So again, integrated treatment makes perfect sense and likely increases the outcome. So again, we come back to the template here. And as we know that in cognitive therapy of for whatever disorder, there's relapse prevention. And there's also Kathleen Pike's relapse prevention protocol for anorexia nervosa. Those who have done full weight restoration and come out of a program, they do much, much better if they then do the relapse prevention rather than just treatment as usual. So I hope that this is useful to you. I'm going to move on and mention a few things about DBT in my last few minutes, as well as family therapy. I think, again, most people have some awareness of what DBT is. It's a highly organized and structured specific treatment hierarchy. It uses a behavioral treatment approach. It uses contingency management, which is a component that's used often in substance use, and a lot of times people in the eating disorder world are using contingency management and they don't even know it. It uses dialectical thinking, where you can embrace opposites, apparent opposites, in particular acceptance or validation and change, that you can accept that people are doing the very best that they can right now. And this is great for therapists too, and that's what I love about Marsha Linehan, that you all out there embrace that you're all doing the very best that you can, but you're also, as evidenced by being on this webcast, you're embracing change and you know that you want to learn and can learn about other things and improve. So it's that dialectic that I think is very powerful. It's taking the non-judgmental stance. Again, mindfulness. A lot of her stuff came out of Buddhist psychology. It's also based in emotion regulation theory. And their priorities in the target hierarchy. Of course, life-threatening behaviors, self-injurious and suicidal behaviors are at the top of the rung. And guess what? Starvation, purging, cutting, of course, but outright eating disordered behaviors are self-injurious by definition and are a primary focus, as is substance use. And then you focus on therapy interfering behaviors, which may not directly be harmful, but interfere with the course of treatment. Avoidance of trauma, avoidance of dealing with moving forward and talking about how they got this way in the first place, or what triggered it, or what were the predisposing factors and precipitating factors of their course of illness. Often you have emerged the avoidance component of PTSD, which is often linked to the hyperarousal component and intrusive symptom component of PTSD, as well as now the cognitive component that's part of DSM-5 for PTSD. And then quality of life issues, improving one's life. And again, often this is about dealing with their prior traumas and PTSD once you get the eating disorder and substance use disorder under control. I'm showing this again, just to emphasize, this is the only thing that's been shown for the ED substance use disorder patients. DBT for PTSD after childhood sexual abuse has also been used in patients with and without borderline personality disorder. This came out in 2013, a randomized controlled trial. So there's mounting evidence for the use of DBT. It's certainly been used in the eating disorder world, particularly in the bulimic arena. You may be familiar with radically open DBT, which has been developed for over-controlled patients and is being studied now at the Maudsley and other places. We don't have time to get into that today, but DBT interventions, there are a number of components to it, most notably the skills, but keeping a diary card. Again, this is behavioral monitoring, behavior change. This is straight out of cognitive therapy. Now, structuring the environment, involving parents, that's also very much speaking my language. Having a family component, using contracts, contingency management, consequences, outlining the specific consequences, particularly the positive ones, are very, very important in DBT. The idea of skills generalization. So if you learn mindfulness for one thing, you can apply it for another. If you learn distress tolerance for one thing, you can apply it to other, and so on. So one of the things I also like about DBT is that this concept of rational mind, emotional mind, and where they overlap is wise mind. Very, very useful concept, I think, in working with eating disorders in general, but also particularly the comorbid folks that we're talking about today. And in that middle part where wise mind lives is clear mind. It's also well-nourished mind. It's not, foggy mind where people are when they're binging and purging a lot. So useful concept, part of DBT. We've already gone over the skills training. There is a new second edition of Marshall Linehan's DBT skills training manual. It is like 2 inches thick. It is full of exercises that one can do to focus on these different 4 sets of skills. It's highly useful. There are many other training or useful manuals for using DBT in the eating disorder world. And I want to finalize this by talking about family therapy. And we all know about FBT and the importance of family therapy in those with eating disorders, not only for anorexia nervosa, but it's now been used for bulimia nervosa as well. And similarly, there is a very rich history of family-based approaches used for adolescent substance use disorders. It makes sense since often they too start in adolescence, as do many psychiatric psychological disorders. The sooner you can detect it and intervene at a family level, the better. Not just true for eating disorders. So there's been extensive research, and consistent across all these approaches is the aim to leverage the support of family members to achieve sobriety by making changes within the family environment and to change problematic behaviors and attitudes that will help maintain and encourage long-term recovery. There are several that have been studied with good data to back them up. This is just FYI if you want to investigate that more. These are all outlined in the family therapy chapter of our book that Amy Baker Dennis and I edited. There are also family-based approaches. Well, this is still for adolescents. So these are some of the things that it can do, or has been shown to be able to do, which are at multiple levels in the individual person as well as in the family system. There are also family-based approaches that have been shown to be helpful for adult substance use disorders. Now, you're all probably aware of the approach of intervention that's often used in the treatment of substance use disorders. We people often use interventions in eating disorders as well, although it's not written about very much. There's community reinforcement and family training or craft. There's behavioral couples therapy, similar to UCAN, and there's behavioral family counseling. So at whatever level we're talking about, there has been different forms of family therapy that I think should be part of the mix when you're dealing with such complex and difficult to treat cases. Now, we're at questions. Good, 3:15. We've got 15 minutes for questions and comments. Thank you very much for your attention, and please feel free to ask questions or make comments. I'm really interested in everyone's clinical experience with this population. Thank you.
So this is Terry Fasihi again. Can you hear me better?
So far, so good.
Okay, great. Well, the way we were going to do this is I will read the questions that you type, the participants type into the chat. And I see that Elspeth Humphreys is typing a question right now.
Right. Dawn, are you there?
Are you having any technical issues, Dr. Brewerton?
I need to make. Okay, now I see chat with presenters. Okay.
Yes.
Oh, chat with. I need chat with attendees.
Okay, Dr. Brewerton, Elspeth is asking, do you have any suggestions for outpatient programs and the struggle to address both versus residential programs? Did you hear that?
I see it. I can see it now. Thank you for that question, Tom. Well, at the risk of being politically incorrect, you're asking me to name places that I can recommend. But I think a lot of this is already out there in the public domain, that places advertise and market themselves as places that do both. And I think there are two places that come to mind, and Rosewood is one, which has an inpatient detox unit and treats both people with substance use disorders and eating disorders. That's located in Wickenburg, Arizona. And then the other place that comes to mind is Timberline Knolls, which I believe is in Illinois.
Yes. Is she not asking of the difference between outpatient versus residential?
Okay. You have, well, both of these programs have outpatient programs. So in terms of actually outpatient programs, well, I know Dennis Baker, Amy Baker Dennis does this in her private practice in Detroit. And so I think you have to kind of explore where you are in terms of what is available, because I think there are a lot of places and providers out there who do practice integrated treatment, but we may not know about it, and they're not marketing themselves necessarily in that way. And so I'm not sure. Okay, you're asking about outpatient program in BC, Canada. I am not aware I'm not aware of an integrated program that does both in Canada. There certainly may be. Do you live in Canada?
She works in an outpatient program. Do you think that integrated treatment can be achieved in an outpatient level of care?
Okay, thank you. I'm sorry I didn't understand the question. Do I think it can? Absolutely. It can. And a lot of this stuff is treated as an outpatient, and even if they go away, to a program that's hopefully integrated, they're going to be coming back to you, and you want to make sure that you're part of the team as they go and come back, and that you understand what they're doing and they understand what you're doing and what you want and what the goals are for you and your client or patient. So I think you can practice integrated care even though you're involving other providers, and sometimes you have to, particularly if you're a non-physician and you can't prescribe medicine. We do this all the time, but often there's a vast difference in terms of communication and being on the same page, just philosophically, about treating an eating disorder. Will the slides be shared? Yes, I think so. Yes, absolutely. Dawn, are you there?
I'm here.
Will the slides be shared?
Yes, the entire presentation will actually go online. I don't know that it'll go online today, but probably tomorrow, yeah. And we will send a notice out to everyone who attended so that they could look at it as long as they're a member of AED. And then we'll include it in one of our emails going out. It's behind the portal. It's behind the member portal. So it's one of these benefits of being a member of AED is you get access to this online library.
So is it Elspeth Humphreys? Elspeth? Am I saying it right? Good. Tell me, if you don't mind sharing your experience as an outpatient program in Canada with this problem, and what obstacles you've had, and whether some of the ones I've identified, are relevant to you in your program. And the same goes for all of you out there who are still on the call or the webcast. And what are the problems, but also what possible successes you've had in dealing with this? I would be really interested to know. What experiences have you had with addiction programs, treating, all of the problems?
I'm going to read her response so that it'll be recorded.
Okay.
It's a major challenge. A number of us listen.
So you're breaking up again, Terry, so I'm going to read it.
Okay.
It's a major challenge. A number of us who are listening have started a provincial working group to try and improve care across treatment programs. Yes, great. And can you say more about the major challenges? From what I gather and understand, addiction is a terrible problem in British Columbia, particularly the opiate problem. And I know, meth is a real problem on the West Coast as well. And I think there are a number of screening in substance use program or discharging early if ED symptoms come up. Yeah. So the problem is, or the challenge is, in the addiction side of things, that they don't know how or don't want to deal with the eating disorder folks. Yeah, and eating disorder programs requiring abstinence. Yeah, that's the other side of the coin.
Yes.
Most definitely. And I think as clinicians, you have a voice out there, and you can make your dissatisfaction known to these programs. They want, at some level, to serve the community, and they want to be better. And I think when they hear dissatisfaction from the people who refer to them, it matters to them. What would you say about that, Terry?
Well, I was going to say that I remember I worked for a nationalized healthcare system in the UK for a few years and had similar problems to what Elspeth is describing when I worked there. I hope you can hear me.
Yeah.
But I'm also thinking in kind of US-centric terms about the challenges of the health insurance industry and getting enough coverage to address all the comorbidities and not being pigeonholed as, well, you're just a substance use program or you're just an ED program, so we're not keeping patients there for other issues. That's a problem I've seen in the US.
Yes. I think big time.
Mm-hmm.
And I think, frankly, this level of comorbidity it requires higher levels of skill and integrated approaches.
Yes.
It probably does make their outcome numbers worse because it takes longer to treat. There's a higher rate of dropout if they don't drop you first as a patient.
Yeah.
And there's a lot of negative countertransference, in whatever field you in toward the people who are outside of what your perceived field is. And I think a lot of people in the eating disorder world perceive addictions as outside of their bailiwick and vice versa. And so they feel entitled to kind of, act out on these negative feelings and beliefs that they have. They often believe that people with addictions never get better, which is not true. They often believe that it's untreatable, or they're just plain scared, which comes out of just poor training and not having been trained. Elspeth asked, have you heard of EFFT? And yes, I have. And we're talking about emotion-focused family therapy, which is really an approach that piggybacks on emotion-focused therapy or emotionally focused therapy. Emotion-focused family therapy is kind of the brainchild of Adele LaFrance, who is from Canada and who now lives in Colorado, and she is doing her best to disseminate this. I think it's EFT and EFFT is much more acceptance in Canada than it has in the United States right now. And I know that she and others are working on studying it, particularly in conjunction with FBT. And I'm hoping that will be successful. But yes, indeed, I've heard of it. I know Adele. I've talked with her. I've met with her. I think it's great because I think often the emotions of the parents are often need to be a focus, and it's not a focus of typical classical FBT, in my opinion. Others might disagree with that.
We have time for one more question.
Elspeth is working with Adele on a project with this. That's great. Awesome. I'm glad to hear that. In where families are often traumatized. There's a lot of secondary dysfunction. Not all family dysfunction is primary or come first. A lot of family dysfunction comes secondary to after the onset of the disorder because it's so taxing and so stressful. And keep that in mind as you work with families because we don't want to blame them.
Absolutely. Dr. Brewerton, that was such a fantastic presentation, and we appreciate everyone else's participation, both as listeners and with your questions.
Yeah.
Thank you again, and enjoy the rest of your day.
Very good. Thank you so much, everyone, and Terry and Dawn. It's been a honor and a privilege to do this. Everyone take care.